In continuation with our lecture, let's today look at the classification of oral hypoglycemic agents and their pharmacology. Okay? So that's today's goal for this lecture. So let's see how we classify oral. So let's write classification of oral hypoglycemic agents. So oral hypoglycemic agents can be classified into different types. Okay. The first one would be biguanides, sulfonylureas, alpha glucosidase inhibitors, thiazolidine diones, amylin analogs, and incretin modifiers or incretin modulators, and incretin modulators are again of two types. One is GLP-1 analogs and DPP, dipeptidyl peptidase 4 inhibitors. Okay. And the last one clinically used is SGLT2 inhibitors. Okay. So these are the currently available oral hypoglycemic agents in clinical practice. Okay. Okay. At a later date, more agents might be available, but as of now, these are the oral hypoglycemic agents that is being used clinically. So in this lecture, we're going to talk about biguanides, and sulfonylureas. Okay, so we're going to look at the pharmacology of biguanides and sulfonylureas in this lecture, and the other drugs we'll be taking up in another lecture. Let us discuss about biguanides. The representative drug of this chemical class is metformin. There have been two other drugs, fenformin and buformin. However, these drugs have been withdrawn from the US market. Okay, so the clinically used drug of this class currently is only metformin. Okay. So what does metformin do? Okay, so what's the mechanism of action of metformin? Okay, so MOA refers to, is an acronym for mechanism of action. Okay, so how does it work is what we're going to discuss now. So recent evidence shows that metformin stimulates AMP activated protein kinase. Okay. This is abbreviated AMPK. Okay. AMP meaning adenosine monophosphate. Okay, and in doing so, what does it do? It stimulates this kinase and decreases hepatic gluconeogenesis. Okay. Then what it does is it increases glucose sensitivity. Okay. Yeah. It increases the glucose sensitivity of peripheral tissues. Then it increases glucose uptake in the periphery. Okay. Okay. And it has got cardioprotective effects. Okay. So this drug has got cardioprotective. So this drug has got cardioprotective effects. So what we mean by that is it decreases the risk of MI. Okay, MI meaning myocardial infarction. Okay, so your mortality will reduce. It has got indirect cardioprotective effects as well by reducing low density lipoproteins. Okay, and it also decreases platelet aggregation. Okay, so all in all, if we consider all this three together, it has got beneficial, we could say that it has got beneficial effect on the cardiovascular system. Okay. And in some cases, it produces anorexia, which is kind of mild. So what is anorexia? Anorexia is when people are very concerned about their weight and they decrease their food intake and so on. So anorexia basically leads to decreased body weight. Okay, so that is a beneficial effect again. Okay, so if we consider the other orally use drugs like sulfonylureas. So sulfonylureas, if you consume sulfonylureas, then you gain body weight. Okay, so in this drug, metformin, it reduces body weight. So therefore, it is a drug of choice in obese patients. Okay, by obese we mean overweight. Okay. Okay, so for them it's a drug of choice because of this reason. Okay. So we said the prototype drug in this class is metformin. Okay, and there have also been fenformin and buformin, and we said it has been withdrawn from the US market. So why have they been withdrawn? Okay, so what was the reason why it was withdrawn? Because it caused lactic acidosis. Okay, so what is lactic acidosis? So we said, what does it do? Metformin-like drugs, they decrease hepatic gluconeogenesis. So what is gluconeogenesis? All right, so when we make, you're right, when the body makes glucose from sources other than carbohydrates, it's called gluconeogenesis. So what are the substances from which glucose is made, which is non-carbohydrate? So usually it is from alanine, and it is from pyruvate, and it is from lactate. Okay, so these are the non-carbohydrate sources which get converted to glucose in gluconeogenesis. But this drug, it inhibits hepatic gluconeogenesis, meaning it does not allow either alanine, pyruvate or lactate to be converted to glucose. So in this case, what happens is, this lactate is not converted to glucose because hepatic gluconeogenesis is inhibited. So as a result, lactate accumulates. Okay. Okay. With administration of biguanides. Okay, and that is responsible for lactic acidosis. Okay, so we have written that biguanides cause lactic acidosis, and because of that, these two drugs were withdrawn from the US market. So the question is, isn't metformin biguanide too? Doesn't it cause lactic acidosis? It does. But the instances are comparatively less compared to fenformin and buformin. Okay, so it's relatively safe if the renal function is really good. Okay, but if the renal function gets compromised, then yes, this has got a risk of lactic acidosis. Okay, so we should keep that in mind. Okay. So one of the main adverse effects, the possible adverse effects of metformin is lactic acidosis. Is it very common? No. Okay. But does it exist? Yes. All right. Okay. So now we know why fenformin and buformin was withdrawn from the US market. Okay, because of lactic acidosis. Okay. And what's the advantage of this drug? It does not cause weight gain. And so how is it better than sulfonylureas? It is this aspect, okay? It does not promote weight gain, okay? So, yeah. And the other thing to remember about this drug is that if you think about it, what does it do? It reduces hepatic gluconeogenesis. It increases glucose sensitivity. It increases glucose uptake. But it has got no effect on insulin secretion per se. Okay? It has got absolutely no effect on insulin secretion. Okay? So we could say that, let's write it down here, that metformin is anti-hyperglycemic. Okay, anti-hyperglycemic, but it is not hypoglycemic. Okay, which means it lowers blood glucose. It lowers blood glucose, okay, but does not decrease it below, the normal value, okay. So it cannot cause hypoglycemia. But if you think about the other drug, sulfonylureas are secretagogues, meaning they increase the secretion of insulin. Okay, as a result, if they release more of insulin, what's going to happen? Definitely hypoglycemia will be the main adverse effect of sulfonylureas. Okay, so in studying metformin, we are also learning the disadvantages of sulfonylureas. The sulfonylureas, one of the main disadvantages, it promotes weight gain, and secondly, it causes hypoglycemia. Whereas this drug does not cause hypoglycemia. Okay, therefore, it is a drug of choice. Drug of choice, DOC is the abbreviation for drug of choice in the elderly. Okay. In elderly people who don't consume proper meals, okay, who don't consume meals in time, in those patients, this would be a drug of choice. Because if you don't consume proper meals, what's going to happen? Your blood sugar is anyway reduced, and you're also now consuming, say, sulfonylureas. Then what's going to happen? You're going to go into hypoglycemic shock. Okay? Therefore, metformin is a drug of choice in the elderly and people who don't have proper meal hygiene, who don't consume proper meals, and who exercise excessively. Okay, people who exercise excessively. So these people, they are more likely to suffer the adverse effects of sulfonylureas. So in such people, this is a drug of choice. Okay, so exercise, I just put it in there to give you an idea. Okay, that if you do lots of exercise, what's going to happen? Your blood sugar is coming down, and at the same time, if you are on sulfonylureas, then that might cause hypoglycemic shock. So in such patients, the drug of choice would be metformin. Okay. Okay. The metformin has got, in addition to all these effects, it has got an off-label effect. Okay. So let's write it down here. It has got an off-label use. Okay, meaning it's not an indication, but nonetheless it is being used for this condition. And the condition that we are referring to is PCOS. Polycystic okay, so Yeah. So in such patients also this drug is given. Okay. So it not only has got an hypoglycemic effect, it's also used for the treatment of PCOS. Okay. Okay. So let's talk about the ADRs then. Yeah, there is one more thing that we need to discuss, and that is this drug. Let's write note. Okay. Metformin should be withdrawn before general anesthesia and it should be withdrawn before iodine containing contrast media is administered. Okay. So the problem is why? Okay. So the question is why? The reason being that when a patient is under general anesthesia or is undergoing diagnostic procedures using iodine-containing contrast media, then there can be fluctuation in renal function. Okay, so if there is fluctuation in renal function, then there is a slight risk of lactic acidosis. Okay, there is not a slight risk, there is a risk of lactic acidosis. Okay, but yeah, so it can be temporarily. So what is the solution? The solution is temporarily withdraw metformin. Temporarily withdraw metformin and administer it in about 48 hours. Okay, so 48 hours after the procedure, okay, or within 48 hours of this procedure, it can be reinstated. Okay, so that's the solution. Okay, so now we know why we should be careful in general anesthesia, and then we do diagnostic studies, radiodiagnostic studies. Okay, okay, which brings us to the adverse drug reactions. Okay, so the main one is risk of lactic acidosis. Okay, so this is, yeah, by the way, if a person has got lactic acidosis, it is managed with, because it is, increase in acids or decrease in pH is what causes lactic acidosis. So how can it be managed? Lactic acidosis is managed with, you're right, sodium bicarbonate. Okay. Okay. So as acidosis is managed with a base, in this case it is sodium bicarbonate. Okay. So there is a risk of lactic acidosis. And this lactic acidosis, the risk increases with decreased risk increases with decreased renal function. Okay, so therefore, this drug is not recommended in males with creatinine value greater than or equal to 1.5, and in females with creatinine value of greater than or equal to 1.4, meaning people with compromised renal function, this drug should be monitored. Okay. And the other adverse reaction is it causes GI symptoms. Okay. So which are the most common GI symptoms? Nausea, vomiting, diarrhea. Okay. And general patients might complain of bloating. Okay. And there can be flatulence. What is flatulence commonly called? Yes, it is intestinal gas. Okay. And then there is another effect higher up in the GIT, and that is the patients might feel metallic taste. Okay, and this is kind of unpleasant. Okay, so the strategy, what is the strategy? So this is the problem. Okay, so what is the strategy? What is the solution for this problem? The solution is to start with a low dose. Okay, and then slowly increase, okay, till to a maximum dose. So the maximum dose till the maximum dose of 2000 milligram. Okay, so the commonly used strategy is the standard dose regimen would be, okay, to accomplish this starting with a low dose. So what is usually done is 500 milligram OD once a day is given for 7 days. After 7 days, it is increased to 500 milligram BD, okay, twice a day. That also continues for 7 days. So after that, 500 milligram is administered TID thrice a day into 7 days. Okay, so after that, 2 into 500 milligram is given BD. Okay, so that 2 into 500 grams, meaning 1000 milligrams twice daily. Okay, and that reaches us to the maximum dose. Okay, all right. So the strategy is that people complain of all these problems if we start with a high dose. Okay, so the strategy is let the body get adjusted. So start with a low dose and see whether the patient tolerates. So after 7 days, the patient comes back, and then the patient is reassessed. And then if the patient does not show doesn't complain of a big problem here, then the next regimen is started. Again, the patient is seen after that, and then that ways it can reach 2000 milligram. Okay. So once you start, okay, so let's write it down here again as a small note. Once started, the regimen should be continued
till there is a contraindication. A contraindication, okay. And this contraindication may be if there is therapeutic failure or the patient simply cannot tolerate, okay. But if that's not the case, then it should continue indefinitely, okay. But the patient should be monitored. So what happens in long-term administration? On long-term administration, there can be slight deficiency of vitamin B. Okay. So vitamin B should be, especially vitamin B12. Okay, there can be deficiency of vitamin B12, which can lead to anemia and so on. Okay, so the patient should be monitored and the patient should be supplemented with vitamin B12. Okay, but then this is for long term. This problem is seen only in very long term administration. Yeah. Okay. Yeah. So the tablets that's available is for 500 milligrams. Okay. So the tablet. Okay, strength of the tablet currently available is 500 milligram and 850 milligram. Okay, so yeah, so we know it's given orally, per oral, right? Okay. Now, in people who have got, even after using this regimen and we need to stop it in between, then what is the option? Okay, so then the strategy is there are extended release formulation. Okay, so extended release. Okay, extended release formulations exist. Okay, so what's the advantage of this this extended release formulations? They are dosed OD. Okay, they are given only once daily, and they have less severe GI side effects. Okay, and because the release is slow, this extended release, the release is slow. It's slow. Okay, so if the release is slow, what happens? There is no great peaks. Okay, there is no increased peaks, meaning peak concentration will become less. Okay, so this is another thing that can be done if on administering this low dose for 7 days, the patient has got a problem. Then this could be one of the options. Okay. Okay. So what is the indication of metformin? Okay. So under what conditions is metformin administered or prescribed? So if the first strategy for diabetes is to go for non-pharmacological interventions. Okay, so non-pharmacological interventions may be to decrease the weight, to have a plant diet. Okay, so those things, and exercise, those things are non-pharmacological interventions. Now, when non-pharmacological interventions fail to decrease blood sugar, okay, then metformin is the first line treatment. Okay, so this is a first line treatment. Okay, so this is the first line treatment. Okay, and so what does this do is what we're going to look at next. How is it beneficial? Okay, so if we give it as a first line treatment, what changes does it bring to the blood sugar is what we're going to look at next. It lowers blood glucose, lowers blood glucose by about 25%. It reduces blood glucose by 25%, and the postprandial meaning after food, the postprandial glucose by about 44%, and HbA1c. Okay, it lowers it by 1.5%. Okay, so this is the response that we can expect. Okay, so based on this, we can titrate the dose as well as we can monitor the patient for adequate control of blood sugar. Okay, so this gives us the idea about the kind of targets that we can achieve with respect to blood sugar after administering metformin. Okay. Okay. So let's summarize all this information and write the advantages of this drug. Okay, so the advantages of bioquinides. Okay, so what was the first advantage that we talked about? Yes, it does not cause hypoglycemia. Does not cause hypoglycemia. What's the second advantage? Right, it does not increase body weight. Okay, therefore it's a drug of choice in overweight or obese patients. And what's the other advantage? The third advantage is, which we did not discuss, the third advantage is that it can be given, can be administered as monotherapy or in combination with monotherapy or in combination. Okay, combination with any class of glucose lowering drugs. It can be insulin-like drugs, insulin, or oral anti-diabetic drugs. Okay, they can be combined with any hypoglycemic agent. Okay, but the recommendation of the combination, the oral anti-diabetic drug, the recommended combination is if it is, let's try to draw here. The recommended oral anti-diabetic drug with which metformin should be combined is either incretins or sodium glucose transporters. Sodium glucose transporter two inhibitors. Okay. So theoretically, metformin can be combined with sulfonylureas, they can be combined with insulin, they can be combined with any other oral anti-diabetic drug. But the preferred combination with respect to oral anti-diabetic drugs is to combine it with incretins or the sodium glucose transporter 2 inhibitors, okay, which reduce the absorption. These drugs reduce the reabsorption of glucose from the renal tubule. Okay, right. So this is the preferred combination. Okay, and let's look at the disadvantage. If that's the advantage, then what's the disadvantage? Okay, so the disadvantage is that this drug is, let's write number 1 here. This drug is ineffective in the absence of insulin. Okay. So what are the conditions where the insulin is absent? Let's say if there is a hepatic impairment or there is heart failure. Okay, so hold on. These are the contraindications of this drug. This drug is contraindicated in hepatic impairment, in heart failure, in chronic kidney disease. Okay, so these are the contraindications. So it is ineffective in the absence of insulin. So if a person has got pancreatitis, then this drug wouldn't be the drug of choice. Okay, ineffective in the absence of insulin, like example, pancreatitis. Okay, or pancreatectomy. If the patient doesn't have pancreas, obviously it doesn't produce, he or she doesn't produce insulin. Okay, so pancreatectomy. Okay, so the removal of pancreas, the procedure, this is pancreatectomy. Okay, so in these patients, it is ineffective. Okay, so if there is any condition where there is absence of insulin, then this drug is not effective. Okay, so yeah, and chronic kidney disease, and if the renal GFR, okay, glomerular filtration rate is less than 30 ml, then this drug should not be given. Okay, so these are the contraindications, and this is one of the major disadvantages. Okay, it doesn't have very many disadvantages. Okay, so it's got very few disadvantages. Okay, it has got more of advantages. Okay. Yeah. So if we are asked, what is the advantage of metformin above or metformin above sulfonylureas, then we list out these advantages. Okay, and those are the advantages of metformin over sulfonylureas, which means by now we should be able to say what are the disadvantages of sulfonylureas as a class of drugs, right? Okay, so yeah, so that is the most important aspects about metformin. Let us conclude our discussion on metformin by looking at the structure of metformin. Okay, so we said that it is a guanide. Okay, so which means it has got guanidine moiety. Okay, and what's the structure of guanidine? Okay, so this is the guanidine moiety. Okay, and what is metformin then? It is dimethyl guanidine. Okay, so the structure is dimethyl. So there should be two guanidine molecules. Okay, so the structure would be dimethyl guanidine. So two molecules. It's like NH, and that would be combined with another moiety. Okay, so that is metformin. Okay, so chemically it is a dimethyl guanidine. Okay, so with that, let's stop our discussion here on biguanides. Oh, and let's add a note on the pharmacokinetics of metformin. Okay, so what's the pharmacokinetics? Absorption. So it is absorbed per oral. It has got bioavailability of 50%. Okay, and because it has got a metallic taste, okay, so we said one of the adverse effect is that it's got a metallic taste, so it should be administered with food. Okay, because why should it be administered with food? Because it decreases the metallic taste. Okay, but what's the problem of administering with food? Food may reduce absorption. Okay, so we should be aware. Okay, so titrating the dose, that should be taken into consideration, but patient acceptability will increase if it is administered with food. Okay, so that's about absorption. Distribution. Okay. It is the protein binding. Protein binding is minimal. Okay, so doesn't cause very much drug interactions. Okay, because if it is highly protein bound, then the drugs which can displace it from the binding site can cause drug interactions. So that interactions will be seen more with sulfonylureas. Okay, so sulfonylureas are extremely protein bound. Okay, so they have got lots of drug interactions and metabolism. Okay, so this is not metabolized in the liver. Okay, so there is minimal metabolism of this drug. Again, this is an advantage over sulfonylureas. So sulfonylureas are extensively metabolized in the liver, sometimes into active components and sometimes into inactive. But metabolism definitely happens. Now, if the person has got a problem with their liver, like hepatitis, then sulfonylurea might not be the best drug, but this drug can be given instead. Okay, so that doesn't occur because this is the first line drug. Okay, but we should be aware, right? And excretion. It is excreted through the urine. Okay? So that is the reason we should be concerned about renal failure. So if there is a decrease in glomerular filtration rate less than 30 ml, then what can happen is this drug can accumulate in the body, and there is increased chance of lactic acidosis. Okay. But the important point in pharmacokinetics is that it is excreted through the urine. Okay, so this we have discussed ADME of the drug. Okay, so in the preceding discussion, we have covered the dynamic properties of this drug. Okay, and so yeah, so on this note, let's stop our discussion on biguanides. Let's now discuss about sulfonylureas. Okay, so from the name, one thing is apparent, that there is urea. Okay, so let's see if it makes sense if we look at the structure. So urea, what's the structure of urea? Okay, so this is the structure of urea. So it's sulfonylurea. Okay, so let's draw a sulfonyl group. Okay, so that's a aryl sulfonyl group, and that sulfonyl urea. So aryl sulfonyl group attached to urea group. So that would be okay. So if we split the structure like so, then we see that it has got three parts here. So the first part, as we mentioned, is the aryl sulfonyl group. And this is urea, and that is an aliphatic chain. Okay, R could be an aliphatic chain. Okay, so it's got these three distinct parts to the structure: A, B, and C. So this is basically the general formula of a sulfonylurea. So there are different types of sulfonylureas that differ in this group and that group. Okay, but basically they need structure A and structure B to be called a sulfonylurea. Okay, so these sulfonylureas, they have typical adverse effect. Okay, so the adverse effect
the main adverse effect of this sulfonylurea class of drugs is hypoglycemia. Okay, so there is a reduction in the blood glucose level. But so what's the problem with hypoglycemia? So the problem is the brain needs sugar to function, and if the brain doesn't get glucose, then it becomes depressed, and this may lead to coma. Okay, so the person will be unresponsive to stimulus. Or it may have a cardiovascular presentation, so it may lead to arrhythmia. Arrhythmias, it may lead to cardiac Okay, so it's got a CNS presentation, a CNS effect, and a CVS effect. Okay, so this basically leads to increased mortality. Okay, so this is associated with increased mortality and increased morbidity. Okay, so that's the main adverse effect of this class of drugs. Is this the only adverse effect? No, there are other adverse effects. Now, if you think about it, the structure contains sulfur. Okay, so there is a sulfur moiety here. So if there is any drug which is, this is something general that we need to remember, that if there is sulfur in the structure, then that sulfur is becomes responsible for hypersensitivity reactions, especially those related to the skin. Okay, so it may cause, so the other adverse effect due to the sulfur in the structure is allergic reactions. Okay, and these allergic reactions are mostly urticaria or erythema. Okay, so that's another typical adverse effect. So what's the general thing that we need to remember? We need to remember that sulfur, if present in the structure, always more often than not causes allergic reactions. In this case, it manifests as urticaria and erythmia. So what are the other adverse effects? So we said that hypoglycemia leads to leading to CNS manifestations and cardiovascular manifestations. Let's look some other allergic adverse reactions. Okay, it may cause GI presentation, it may cause nausea, dizziness, headache. Okay, so this is basically a CNS presentation. Okay, yeah, and this nausea can also be caused due to GI effects. Okay, in which case it's associated with vomiting. Okay, so it's got a GI presentation, it's got a CNS presentation, and it causes a specific reaction which is called, let's write it down out here, it's called disulfiram reaction. Okay. So to understand disulfiram reaction, we need to digress a bit and learn about the metabolism of alcohol. So the alcohol that is consumed is called ethanol or ethyl alcohol, and it will get absorbed, and after that it reaches the liver, where an enzyme called alcohol dehydrogenase acts on it, and it requires NAD, which gets converted to NADH plus, okay, and that forms acetaldehyde. Okay, this acetaldehyde similarly is acted upon by another enzyme, and it is acetaldehyde dehydrogenase. Okay, and acetaldehyde becomes acetate or acetic acid. Acetate. Okay, this acetate, in the presence of acetyl-CoA synthase, is converted to acetyl-CoA. Okay. So this is the normal metabolism of alcohol. So there was a thinking that it was known that acetaldehyde, if it accumulates in the blood, it causes certain symptoms in the patient. And the symptoms are, it causes flushing, it causes weakness, it causes nausea, it causes tachycardia. What is tachycardia? Yes, increase in the heart rate. And it causes hypotension. Okay. So these are not very pleasant. Okay, they are not pleasant, but they are not life-threatening per se. Okay, but it's not pleasant to the people experiencing it. So the idea was ethanol is a drug of abuse. Okay, people abuse it. They become addicted to ethanol. So the thinking was, can we give a drug which increases acetaldehyde in the body? Okay, so the logic is, if there is a drug that can increase acetaldehyde in the body, then it will cause flushing, weakness, nausea, tachycardia, and hypotension, which is not pleasant to the person. So, could that be used as a method to wean the people away from ethanol? Was the question. And the answer was in the development of a drug called fomepizole. Okay. Okay. So this drug inhibits aldehyde dehydrogenase. Okay. It inhibits acetaldehyde dehydrogenase. So what will happen if this drug is given on a daily basis to the patient? Let's say, let's write it down here, in a dose of 250 milligram OD, okay, once daily, is given to the person who is consuming alcohol. And every time he consumes alcohol, he has these symptoms. Okay. So when he has this, he or she has these symptoms, then that happens every time they consume ethanol. So it has got a negative reinforcing effect, and the people will be weaned away from ethanol. So that's the idea. So this drug is called an antabuse, okay? Antabuse. Okay, meaning it is given, it comes from anti-abuse. Anti-abuse, okay? It's a contraction of this word, which is what antabuse is. And so the drug that's given as an antabuse is fompizole. Okay, but yeah, so it causes an inhibition of acetaldehyde dehydrogenase. Now, this same reaction, the inhibition of acetyl dehydrogenase, is shown by our drug, sulfonylureas. Okay, so sulfonylureas have got similar effects. Okay, so this acetyl dehydrogenase is again blocked by sulfonylureas. Okay, so disulfiram reaction. So the initial drug that was used against acetaldehyde dehydrogenase was disulfiram. Okay. Okay, so the initial drug that was used for as an antabuse was disulfiram, and now there is this drug, fompizole, as well. So sulfonylureas mimic the action of disulfiram. What do? They inhibit acetaldehyde dehydrogenase, and so sulfonylureas manifest the disulfiram reaction. Okay, so that's another adverse effect of sulfonylureas. So what are the adverse effects that we have covered? Sulfonylureas, first and foremost, causes hypoglycemia, and because of the presence of sulfur, it causes allergic reactions manifested as urticaria and arrhythmia. And it has got GI as well as CNS manifestations. In GI, we've got nausea, vomiting. Okay, and CNS is nausea, dizziness, headache due to this drug. And it inhibits acetaldehyde dehydrogenase, and therefore it causes the disulfiram reaction. Okay. Occasionally, in addition to this, let's write it here. Occasionally, it also causes hematological manifestations. Okay. Hematological. Okay. And the examples are, it may cause leukopenia. It may cause thrombocytopenia. It may cause cholestatic jaundice. Okay, so these are the hematological manifestations. Okay, and this is a manifestation where it blocks the common bile duct and it causes jaundice. Okay, so this is the manifestation in the liver or hepatic manifestation. Okay, or it may cause dermatological effect, which Okay, we have already talked about the dermatological reaction. What's the dermatological reaction? On the skin, it can cause urticaria. Okay, so that is the dermatological manifestation. It can cause urticaria. Okay, so this gives us the should give us an understanding about the main adverse effects of sulfonylureas. Okay, and the main one, the hypoglycemia, is not shown by which drug? Biguanides. Okay, so yeah, so that's the advantage of biguanides over sulfonylureas. Okay, right. So when we talked about insulin, we mentioned that in the body, in the physiological conditions, there are two types of insulin release. Okay. Yes, so if we look at 24-hour, this is insulin concentration. This is time, and this is breakfast. And here you have breakfast, you have lunch, and you have dinner. Okay. So usually, whenever food is taken in, there is a massive release of insulin from the body under normal physiological conditions. Okay, so this is under normal physiological concentrations. Normal physiology. Okay. Normal physiological condition. Okay, so the insulin release during meals, this is called prandial. Okay. Prandial. These are all prandial. Okay. Prandial blood insulin release. Then there is this basal level. Okay, so it is this level. So this is called basal insulin level. Okay, so under physiological conditions, there is a prandial release and there is a basal release. So sulfonylureas increase both prandial and basal insulin concentration. Okay, so that's the important thing we need to remember before we go into the mechanism of action. So let's write it down somewhere out here. We say that sulfonylureas increase both basal and prandial insulin levels. Okay, so sulfonylureas increase both basal and prandial glucose levels. Okay. So let's look at the mechanism of action. Mechanism of action, abbreviated MOA. So from this, what do we realize from this graph? That sulfonylureas increase both basal and prandial insulin levels, which means sulfonylureas release insulin. From which cells secrete insulin? From the beta cells of pancreas. Okay, they release insulin from beta cells of pancreas. They make the pancreatic cells secrete insulin. Therefore, sulfonylureas are called secretagogues. Okay, so anything that increases secretion, we call it a secretagogue. Okay. So what secretagogue? Insulin secretagogue. Okay, so they cause secretion of insulin from the beta cells of the pancreas. Okay. So how do they do that? That's what we're going to discuss now. So sulfonylureas okay, they bind to a particular area of the potassium channel called the sulfonylurea receptor. Okay, so SUR1. Okay, and what is SUR1? Sulfonylurea receptor 1. Okay, so that is SUR1. So it binds to SUR1, and what does it do? Bind to SUR1. Where is SUR1 located? SUR1 is located on the ATP dependent potassium channel. Okay. Okay. SUR1 is a site on the ATP dependent potassium channel. SUR1 located on ATP dependent potassium channel. Okay. So what does it do? This binding blocks the receptor. Okay. So binding of sulfonylurea to SUR1 site on ATP dependent potassium channel blocks the channel. Blocks the channel. So this blockade, what does it do? This blockade depolarizes the pancreatic beta cell. Okay, depolarizes the pancreatic beta cell. Now, depolarization of this cell, pancreatic cell, results in opening of voltage-gated calcium channels. Okay, so there is calcium entry into the cell. And what does that do? It leads to exocytosis of vesicles containing insulin. Okay? Okay? It does one other thing. Okay, so this is one mechanism. The second thing it does is this drug increases beta cell sensitivity to glucose. Okay, so it increases beta cell sensitivity to glucose. As a result, it releases more of So what happens if it increases sensitivity to glucose? What does that mean? What it means is because of the action of sulfonylurea, what will happen is glucose transporters, okay, but this is insulin independent glucose transporter, okay, and that is called GLUT2. And where is it located? On the beta cells of the pancreas. Okay, in this case there is only one cell, so we'll write beta cell of the pancreas. Okay, so what's going to happen? Lots of glucose will come inside the cell, and what will happen? It will be metabolized to ATP, and this ATP basically would block the potassium channel, okay, because it's an ATP dependent potassium channel, okay, and that will cause increased release of that. So this ATP will cause blockade, okay, if that's the potassium channel, and it will cause a blockade of the potassium channel, ATP dependent potassium channel. Okay, so that is blocked. As a result, it will depolarize the cell, and what's going to happen? All the vesicles containing insulin will fuse with the membrane of the beta cells, and then there will be exocytosis. Okay, so this is what this is the effect of glucose on the beta cell of pancreas. Now, in our case, what is happening is there is less sensitivity of the beta cell to insulin, okay, because this is a diabetic patient. So what does this drug do? It directly goes and blocks the ATP dependent potassium channel. Okay, so, and subsequently it also increases sensitivity to glucose. So initially in diabetic patients there is decreased sensitivity to glucose. Okay, so in diabetes mellitus there is decreased sensitivity of the beta cell to glucose. Okay, and we have talked about the physiology. So normally in absence of pathology, glucose will directly enter into the cell, become ATP, and that ATP will block the potassium channel, and that blockade will result in entry of calcium. Okay, and that calcium will cause exocytosis of the insulin containing vesicles, and that exocytosed insulin will cause the effects of insulin. But in a diabetic patient, this channel is not very sensitive to glucose, and therefore directly the potassium channel is blocked by sulfonylureas, which act on a particular area of the ATP dependent potassium channel, which we call SIR. All right? Okay, SIR1. So these are the two important mechanisms of actions of insulin. Okay. So what's important to remember here is that insulin has got absolutely no effect. Okay. Insulin has got no effect on insulin biosynthesis. Okay, it has got absolutely no role in how insulin is synthesized within the cell, But what it does is whatever stored insulin is there, that is released. Okay. So for sulfonylureas to work, therefore, for sulfonylureas to work, it needs functioning beta cells. Okay, so usually greater than 30%. Okay, of beta cells should be viable, only then this drug has got some effect. But what if there is no beta cells, beta 2 cells? Then it cannot work. Okay, it requires functioning beta cells. So that is why in type 1 diabetes, mellitus, the functioning beta cells would become drastically less. Okay, so let's say less than 30%. Okay, so in which case this sulfonylureas will not be clinically effective. Okay, so that is the reason why sulfonylureas are not given for type 1 diabetes mellitus, because they've got less number of viable beta cells. Okay, so that's useful for us to remember. Okay, so therefore, what is the best way to institute the therapy? So it would be worthwhile to remember that the biosynthetic pathway of insulin. So we've got pro-insulin, which is present within the vesicle. This pro-insulin gets converted to insulin within the vesicle. Okay, within the insulin containing vesicle is where pro-insulin gets converted to insulin. So now what we understand from pro-insulin is, what is pro-insulin then? If this is A chain of insulin and this is the B chain, and these chains are held together by disulfide bonds. Okay. Then there is a connecting chain between the A chain and the B chain, that is called C peptide. Okay. And this C peptide is, so the A and B chain along with C peptide, this whole combination is called pro-insulin. Okay. We said pro-insulin is converted to insulin within the vesicle. So in the vesicle, what happens? The pro-insulin, from the pro-insulin, this C peptide minus C peptide. So the C peptide is removed, and that totally gives insulin. Okay. So each vesicle would contain insulin, it would contain C peptide, okay, and various other cellular components, okay, but cellular metabolites, okay. But what is important to remember here is for each insulin molecule, a C peptide is present. Okay. So on exocytosis, so when exocytosis takes place, what is exocytosed? Insulin and also C peptide. Okay. So for each insulin molecule, a C peptide is also secreted. So this insulin has got a very short T half in the body. Okay, it's got a very short T half. The endogenous insulin has got a very low T half. Therefore, but C peptide has got a greater T half. So C peptide is an indirect measure of the insulin synthesizing capacity of beta cells. So we said that sulfonylureas require a functioning beta cells in a quantum greater than 30% to be effective. So the best way to institute therapy is to make sure that there are insulin secreting cells already present in the patient. Okay. So how will we know whether there is insulin producing cells in insulin producing beta cells in the patient? We can assess that by looking at the concentration of C peptide. Okay, so that is the relevance of C peptide. Okay, so C peptide is a indirect measure of the insulin synthesizing capacity of beta 2 cells. So the normal C peptide level, let's write it down here. The normal C peptide level is 0.5 to 2 nanogram per ml. So Ng is nanogram. Okay, nanogram per ml. So if the concentration of normal C peptide is less than or significantly less than 0.5 nanogram per ml, then that patient might not be a good candidate for the institution of sulfonylureas as a drug. Okay, so ideally the C peptide level should be assessed before instituting treatment with sulfonylureas. Okay, so it's important to remember this as well. Okay. Okay. So we mentioned that sulfonylureas causes, what's the main adverse effect of sulfonylureas? Yes, it causes hypoglycemia. Okay. So the question is, can we diagnose hypoglycemia in the lab? Yes, we can. If suppose the patient is having a hypoglycemic attack and it has been managed, but before managing, if some bit of blood is removed from the patient and subjected to analysis, what is usually seen is insulin is seen at a concentration greater than 3.9 micro international unit. Okay, so international, what is IU? International unit, okay. Okay, so that is how insulin is quantified, and insulin can be seen at this concentration. So we are talking about hypoglycemia induced by an overdose of sulfonylurea. The blood picture, okay, or the blood analysis would show insulin to be greater than this and C peptide would be greater than 1.4 nanogram per ml, and glucose. So we are talking about hypoglycemia, so glucose should be really less. So glucose would be 40 milligram per deciliter. Okay, so this picture is consistent with sulfonylurea induced hypoglycemia. Okay, so that would be the blood picture. So glucose will be considerably reduced and C-peptide would be increased and insulin will be increased. Okay. And this reduction, the hypoglycemia would persist for sometimes 1 to 2 days. Okay. So it's a prolonged hypoglycemia. Okay. So which is what the adverse effect of sulfonylureas are. Okay. It's a prolonged hypoglycemia. Okay. 1 to 2 days. Okay, so we talked about the adverse reactions. There is one more adverse reactions that would be useful if we can list it around here. Okay, so the other adverse effect is, in fact, let's write it somewhere there. Okay. So another adverse effect would be there is evidence that sulfonylureas cause teratogenicity. So what is teratogenicity? These are basically abnormalities in the developing fetus. Okay. So what are the abnormalities that are seen? There is microtia. There is deafness. There can be facial deformities. There can be ventricular septal defect, or there can be atrial septic defect, or there can be single umbilical artery. Okay, so there is evidence that sulfonylurea given to pregnant women can cause these abnormalities in the fetus, which is basically teratogenicity. Okay. Okay. If it is administered to pregnant women in the first week of pregnancy. Okay, so if the pregnant woman is administered sulfonylureas in the first week of pregnancy, then there have been case reports of teratogenicity. Okay, because if you think about it, you're administering it at the first week, and all these things are organ defects. So organogenesis happens in the second week. Okay, 2 to 8 weeks we'll have organogenesis. So that is why there is interference with normal organogenesis. Okay, so 2 to 8 weeks these manifestations would be seen. Okay, so what happens if it's quite early in pregnancy, say maybe first or second or third day?
what happens to the fetus if it undergoes some insult. All right, yeah. So there will be a spontaneous abortion, okay. So, yeah. Okay, so there will be interference with organogenesis. Organogenesis happens 2 to 8 weeks, okay. There is organogenesis, and prior to 1 week, okay. If there is an insult, okay, meaning some chemicals is given before the first week of pregnancy, then there can be abortion. Okay, if the exposure happens after 8 weeks, then what can happen? There can be developmental abnormal or functional abnormalities are seen, but that is what happens in teratogenicity. Okay, but in this case, in sulfonylureas, it is administration at the first week of pregnancy, when teratogenicity that we have listed can happen. Okay, so what's the solution then? This is a problem. How can we solve the problem? Very good. Don't administer it to pregnant patients, okay, who are our clients, okay. So we should not administer sulfonylureas to pregnant women. So then what else can you give? If you so definitely pregnancy, there is what? There is gestational diabetes mellitus, okay. So there is gestational diabetes mellitus is seen in pregnant women. Okay, but to reduce their blood sugar, we cannot give sulfonylurea. So what can we give? Right. So what can be given, what can be administered is insulin. So insulin is the drug of choice for gestational diabetes mellitus. So as far as possible, oral drugs should not be administered. Okay. Yeah. Okay. So now let's talk about the pharmacokinetics of sulfonylureas. Okay. So let's look at pharmacokinetics. Okay. And we're going to look at absorption. Okay, so it is administered per oral. Again, on administration orally, it is well absorbed. Okay. Food can decrease absorption. Hypoglycemia itself can decrease absorption. Okay, hypoglycemia, if the patient is hypoglycemic, when you administer the drug, that itself can interfere with the absorption. Okay, right, absorption, distribution. Okay, so the general thing to remember, let's write it somewhere out here. Okay, so the general thing to remember is that sulfonylureas, let's zoom it up here. Okay, so sulfonylureas are metabolized in the liver. Okay, and sometimes the metabolite can be both active or inactive. Okay, and these active or inactive components are excreted in the urine. Okay, so because it is metabolized in the liver, patients who are having hepatitis or any hepatic insult, in them the dose needs to be adjusted or they might be contraindicated. Okay. So in liver failure and kidney failure, we have to pay special attention. Okay. So assess what function? Liver function and kidney function. So ideally, before administering sulfonylurea drugs, the liver function and kidney function should be assessed. Okay, because we need to know. Okay, if there is liver problem or there is a kidney problem, then it can interfere with the entire metabolic processes that sulfonylureas undergo. Okay, so let's come back to what we were writing about the pharmacokinetics. So the other important thing to remember about distribution is that these drugs are 99.9% bound to plasma proteins. Okay, specifically which protein? Albumin. Okay. Okay, so drugs which bind at the same site on the plasma proteins can cause a displacement type of drug interaction. Okay, so therefore, because of this reason, there can be displacement drug interactions. Okay, so if it is concurrently given with, say, a highly protein-bound drug like warfarin, then there can be potential drug interactions. Okay, and T half is short, around 3 to 5 hours. 3 to 5 hours. Okay, so theoretically by 5 hours, it should begin to lose its effect. But hypoglycemic effects are seen up to 12 to 24 hours. Okay. That is the reason why these drugs are administered. So sulfonylureas are administered once daily. Okay, because of this reason. Though they have a short half-life, the hypoglycemic effects persist for 12 to 24 hours. Therefore, they are given OD. Okay, and they are susceptible to displacement type of drug interactions. Metabolism. Okay, metabolism, we have already mentioned that liver metabolizes it to both active and inactive components. Active components. Okay, so metabolism is through the liver. And what about excretion? We said the metabolites are excreted through the kidney. Okay, so there is one more thing to remember here, that in distribution 99% is bound to plasma protein, and the plasma protein is greatest for, I'll write it down here, plasma protein binding is greatest for glyburide. Okay. Glyburide is a drug sulfonylurea, second generation, that is having the greatest plasma protein binding property. Okay. All right. So what did we study up to now? We talked about the ADME of the drug. Okay, so A is absorption, D is distribution, M is metabolism, and E is elimination. Okay, so these are the most important pharmacokinetic characteristics of sulfonylurea drugs. So now let's look at what are the drugs. Okay, so for that these drugs are classified. So let's talk about classification. So we'll talk about classification. Classification of sulfonylureas. Okay, so it is classified into 2 generations. Okay, it is classified into 2 generations. So the classification scheme, so let's write it down here. Classification scheme is largely based on differences in potency, potential for side effects, and binding property. So binding to what? We mean plasma proteins. Okay, so based on these considerations, sulfonylureas are classified as first generation, and second generation drugs. Okay, so now let's look at what are the examples of first generation and second generation drugs. All right. So the first generation drugs, which came into the market early, these drugs, the examples were, okay, the first generation drugs examples are tolbutamide, okay, chlorpropamide, acetohexamide, and tolazamide. Okay, so these are the first generation drugs. The second generation drugs are glyburide, glipizide, and gliclazide. Okay, gliclazide. Okay, so these are second generation agents. Okay, and glyburide is also known as glibenclamide, right? So
that's just for you to remember. Okay, so there are first generation and second generation drugs. Now, the second generation, so we said the classification is based on differences in potency. The second generation drugs are almost 400 times as potent as first generation drugs. Okay, but we said it is also based on the potential for side effects. So first generation drugs have more side effects, increased side effects compared to second generation drugs. Okay, but that's not necessarily true, because long-acting drugs will have potential for hypoglycemia. Okay, but yeah, and almost all these drugs are highly protein bound. Okay, so the binding property is almost similar, so that's nothing much to write home about. Okay, so yeah, so the important thing to remember here is the second generation agents are most potent. Okay, all right, and we are talking about now these drugs are insulin secretagogues. Okay, we need to remember the glyburide. It's also known as glibenclamide. Okay. The first generation agents, it's not, it's rarely used. Okay. Nowadays, the drugs that are more commonly used are the second generation drugs. Okay. And we are going to look at the duration of action. So the thing to remember here is shorter the duration. So this is again, let's write a note and say shorter acting drugs have got reduced side effect. Okay, so they tend to produce less of hypoglycemia, which means longer acting drugs, there is increased chances for side effects. Okay, so longer acting drugs, there will be increased side effects, and which is the side effect that we are most concerned with? We're most concerned with hypoglycemia. So, okay. So let's look at the different duration of action of drugs. Okay, so let's write down tolbutamide. Let's label it properly and say this is the drug, and we're going to look at the duration of action. And we'll look at the daily dose range. And doses per day. Okay, and the first drug that we're going to look at is tolbutamide. And tolbutamide has got a duration of action of 6 to 10 hours. Okay, so let's write it here, hours. Okay, and the daily dose range is 1 to 3 grams, and the number of doses per day is 2 to 3. Let's look at this second drug, chlorpropamide. we look at this drug, it has got a duration of action of 24 to 72 hours. Okay, so we've already mentioned hours out there. Okay, 24 to 72, and the dose range is 100 to 500 milligrams, and the number of doses per day is 1. Okay, why 1? Because it's got a long duration of action, chlorpropamide. Let's look at acetohexamide. Okay, so this has 8 to 12 hours, and the dose is 0.1 to 1.5 gram. This is more potent. Okay, and 1 to 2 doses are given daily. Tolazamide. Again, 12 to 18 hours. Okay, but the dose is 100 to 1000 milligram. The daily dose range. So this is all milligram unless mentioned. Okay, so yeah, and tolazamide again 1 to 2. Okay, so these are all of historical importance. Okay, they are not currently very much used in the clinic. So let's look at glyburide, and what's the other name? Glibenclamide. How much is that? It's 16 plus, and this is 2.5 to 20 milligram, and 1 to 2 doses are administered. What about glipizide? That is greater than 6 hours. Okay, 2.5 to 20 milligram again, 1 to 2 doses. Okay, and what about gliclazide? That again has 6 to 12 hours of duration, and the dose range 80 to 240 milligrams, and again 1 to 2 doses are administered. Okay. So now if we look at this data, what do we understand? The shortest acting drug among the second generation agent is glipizide. Okay, so because it has got a very short duration of action, the adverse effect profile would be less, so it causes least hypoglycemia of the drugs that we have discussed. Okay. Okay, we got to remember that sulfonylureas they do not interfere. They don't interfere with the disease progression. Okay, so this means that the diabetic patient, they are going to continuously see a decline in their beta cell numbers. Okay, and the sulfonylureas, they require functioning beta cells. So it's quite intuitive to understand that sulfonylureas on long-term use will lose their efficacy as the beta cells continue to decline. Therefore, the patient should monitor. So patients should monitor their blood sugars, and and reassessment should be done every 6 months. Okay, so they need to visit the physician every 6 months, okay, for assessment of their blood glucose as well as system-wide assessment of their body. Okay. So the caveat is that short-acting sulfonylureas may be safer than long-acting drugs. Okay, so that's the caveat that we need to keep in the back of our mind. We should also remember that hypoglycemia may occur with the concurrent administration of drugs, like if the patient is consuming alcohol. Okay, so in alcoholics, we have to remember that this drug can cause disulfiram-like reaction. Okay, so when we take the patient history, and if the patient is a person consuming alcohol, so this the disulfiram reaction should be explained. And alcohol also causes additive hypoglycemia when given with sulfonylureas. And drugs like aspirin, okay, sulfonamide antibiotics, and sometimes sulfonamides and trimethoprim is given. Okay, so this can all cause hypoglycemia, so it's kind of a drug interaction. The effectiveness. So this drug should be administered 30 minutes before meals, okay, to derive the maximum benefit. So after 3 to 6 months, what will happen is the blood sugar levels, when we say blood sugar, we mean the blood glucose level. Okay, so let's make it clear here. Blood glucose is what we mean. The blood glucose levels would fall by 54 to 90 milligram per deciliter. Okay? And the HbA1c levels would fall by about 20%. Okay, so after 3 to 6 months, we should be able to see a decline in the blood sugar level, and this should be intimated to the patient so that the patient, when they monitor their blood glucose, they are aware. Okay, they can see the efficacy of the drug that they are consuming. Okay. All right. So those are the most important aspects of sulfonylureas.